Well, welcome.
This is gonna be a nice informal.
Yes, you will have all kinds of time to ask questions, so that will be nice for you. And there is one woman online named Kathy. So Kathy, you can also chat in with any questions, and please treat this very informally. So we have information materials here, but we are happy to stop, pause, pivot if you have specific questions. This is part of the agency's mission to give back some to the community. So we started this last year trying to offer these educational talks to community members. There is another one in August. The date is
August
18th, maybe?
19th.
August 19th. If you want to hear this again, you could go there too. So this has material for the shoulder, the hip, and the knee. Just out of curiosity, is there one joint, the knee?
Yeah.
Okay, and Kathy, if you wanted to chime in what you were most interested in hearing about, we can kind of move over some of the other stuff as well.
Knee and shoulder.
Knee and shoulder, okay, we'll cover it all. We'll add a little hip in there to spice it up as well. So what you can expect from today is information on how to prepare, maybe what some equipment you may need, what exercises you could be thinking about specifically for the hip and the knee. We'll talk a little bit about shoulder considerations as well. And then also to just look at timelines. I think that's a really important part of the process to understand and mentally prepare for what that road to recovery looks like. We do want to put a disclaimer here that this information is really surgeon dependent and also obviously depending on what kind of surgery that you're getting and to what joint. We're first going to talk about the knee and the hip. So a total knee replacement is also called a total TKA. So if you see TKA, that is what it's referencing, and THA is total hip. With the knee, you have the femur and the tibia involved, sometimes the patella, usually not. For the hip, it's the femoral head and the acetabulum, and that is where you're getting the artificial components. So for both the considerations for hip and knee, it's generally degenerative changes that lead people to receiving an elective surgery for either of those joints. However, fractures, generally hip and or avascular necrosis, would also be indications to proceed with a joint replacement. And generally surgeons will look for you to fail conservative treatment. They're not just jumping in to add something to your body. If you want to compare a hip to a knee is a longer recovery and is generally a little bit more complex, really related to the biomechanics and what you're trying to, the motion that you're trying to regain. A total hip is more straightforward, but you do still have risk of dislocation, even though the dislocation risk factors are reduced because now they're doing mostly minimally invasive surgeries for the hip. So not to be a sad Sally about a knee replacement, but it is a harder recovery than a hip if we're comparing like a hip and a knee. And we're really only comparing because they're both the lower extremity, and there are otherwise a lot of similarities with equipment and exercises.
Sorry, just getting a little closer to you.
It's just what I always wanted.
I know. Thank you.
Yeah.
Yeah.
Going to the upper extremity, with the shoulder, it's your glenohumeral joint. A total shoulder surgery is also known as a TSA. Usually those are indicated if you have advanced arthritis. Sometimes fractures will end up in a shoulder surgery as well. And a lot of times there are questions on whether or not someone is receiving a regular total shoulder or a reverse. And there's a lot of biomechanic considerations, so I'm not gonna get into the details of that. Unless you really want to hash that out, we can. But really it's a surgeon's decision and it's based on the integrity of your rotator cuff. If your rotator cuff is shot, has a lot of damage, isn't stabilizing the joint, then they opt for a reverse, because they use the deltoid as a stabilizer.
So right now, Kathy's saying she has a torn rotator cuff and not looking at total surgery, shoulder surgery at this time.
So looking at a potential rotator cuff repair. Yes. Okay. So in that case, the protocols are actually relatively similar for a rotator cuff repair and a total shoulder. And then it's very dependent on the surgeon's protocol. We're gonna get into some of the like early immobilization period, and we can kind of look back at forth at a rotator cuff versus total shoulder. But be prepared to be in a sling for a while, I think. Like this says for recovery and rehab for both the total shoulder and the reverse, that you're in a sling for generally 4 to 6 weeks. And that's largely true for most surgeons with just the repair and not the replacement.
So I'm turning Kathy's mic on so she can just ask questions.
Oh, okay.
Yeah,
Hi, Kathy.
And,
Hi.
can we hear you?
Hi, can you hear me? I've got headphones on.
Wonderful. So she was just added, not immediate surgery, hopefully never. But now you can speak for yourself.
With that said, if you have a rotator cuff tear and you're hoping to not have surgery, I feel like I'm talking to the owl, like she's gonna be right there. Probably a PT referral and have a PT assess.
Yeah, I've already done that. I just got a second opinion and I'm hoping it doesn't hurt enough that I need to have surgery right now. So I'm good. Thank you.
Oh, good. Lots of strength.
I just saw Dr. Aronowitz in Bangor yesterday, actually.
Oh, yes. She's incredible. Good choice. So we're gonna move on to talking about how we would prepare for an elective surgery. And really you could include rotator cuff for this too, I think. I'm gonna give the overview and then Katie is gonna talk more specifically about some of the exercises, and then Kyla's gonna talk more specifically about equipment and preparing the home. Oh, sorry. So just recapping the overview. So exercises, practicing with equipment, and then also just moving your body as much as possible. So preparing your body kind of more holistically. And that includes also mentally trying to reduce stress, preparing your home, and then making sure you have the right equipment and care planned for post-op. So Katie is now going to move into talking about the exercises for the hip and the knee. We didn't put together any exercises for the shoulder. And that was done intentionally because the shoulder tends to be a lot more specific to the individual. I think we can give general prehab exercises for a hip and knee. And then if you want something more specific, you could get a PT referral for an outpatient evaluation for like how to prepare for your surgery.
Okay.
Just getting out of the way.
You should have done it in order.
Yeah.
Speak right in if you have.
Okay. So we have a handout of these exercises that you can look at. There's written descriptions of all of them, as well as how many repetitions and how many times per day. It's kind of hard for me. I can't really show you visually an example, I guess, standing here talking into a microphone, but there's pictures and written descriptions along with each one. So some of them are starting out lying down, a straight leg raise, keeping your leg straight and lifting it up. The next one is sliding it out to the side, lying down, hip abduction. Ankle pumps, moving your ankles up and down. The next one is a heel slide, just sliding up your heel and bending your knee. And we have, quad sets, pushing down the back of your knee down into, like the bed, if you're doing them on the bed, and squeezing your thigh, holding that for 5 seconds and then relaxing. And then squeezing your buttocks muscles is the next one, holding that for 5 seconds and then relaxing. And the last lying down one here is putting something underneath your knee, like a bolster or a pillow fold in half or a rolled up towel. And resting your leg on that and kicking up your foot and squeezing your knee straight. There's a couple of them in sitting as well. This one is it's called a long arc quad, but you're just squeezing your knee straight and kicking up your foot and then sliding back and bending your knee and sitting. And a couple standing ones would be kicking out to the side and standing and keeping your leg straight and bringing it back behind you for hip extension. And just doing these exercises a couple of times a day to help prepare your muscles before surgery can make a really big difference before surgery if you start out stronger.
Who likes to go
Hi, I'm Kyla, I'm the occupational therapist. So our focus really is usually on ways that you can prepare your home for safety. It's going to be a lot easier to do that before you have your surgery. I see people try to do it afterwards, and it's a lot more difficult. So really being prepared, you've navigated in your environment the way it is, which is great. But when you come home, you're going to have a lot less stability. You're going to be dealing and managing with pain. So there is, for the wide audience, there is a checklist, a safety home checklist. You can kind of get these online. You can also get them if you do end up with OT, they can make you sort of a tailored one. And then there's also a list of equipment, just various equipment, what it's used for. The biggest things you want to make sure is that you're safe in your home. So when you're ambulating or walking around, that you're not, throw rugs are secured. Best practice is just to remove anything you can trip over if you doesn't, feel that you want to do that, or you can't for some reason. Carpet tape underneath to make sure it's really not a trip hazard. Making sure no cords are out. Really good lighting. You don't want to be navigating with new equipment in the dark and have it fall on top of everything else. So our big thing is fall prevention, and the way you can do that is making sure that you're really set up at home as clear of any obstacles as possible. Wearing loose clothing because you're going to need to navigate. Toileting is going to be it's amazing how the things we do every day, and that's what OT focuses on, get a lot harder after you've had a significant surgery or an illness. So things like going to the bathroom, having what we call a bedside commode. It's not everybody's favorite. People don't always love to have it, but it's really helpful. Means you don't have to go so far to your bathroom depending on how far your toilet is to access. And making sure you're able to do proper transfers and safely get to the commode will mean you just don't have to, try to add that to your recovery of trying to get back to where you were before going to the bathroom. We have a couple pieces of equipment that, thank you so much, my lovely assistant has to change. So this is called a Sockaid. This is one of the best things, especially for a knee or a hip replacement, when there's going to be likely some precautions about not bending a certain way. I don't know if anybody can see that. Ooh, which way does it go? There it is. It's a really simple device, really effective. If you haven't seen it before, essentially it just helps you load the sock onto the front. You drop it down in front of you. You slide your foot in. I know the people at home can't see that, but and it's a way that just means you're not bending that joint. You're not bending either your hip or bending past a certain point and causing injury. So this, I would always recommend everybody invest in one of these. I've had people say they don't like them, then they've used them and they love them so much they kept using them after their recovery. So they're popular once you get used to them.
What's it called?
It's called a Sockaid. Yep, a Sockaid. Yep, and you can get them online. You can get them. Sometimes we have them for available loan at the loan closet. You can kind of get them. I think Walmart's even selling them now, so they're more available. There is a technique. You can also look it up. Use a towel. If you don't have one of these, you can kind of do a similar thing. But I would always recommend the actual equipment is better. just because it's a solid piece of plastic. And then the other piece was
You're selling it so well, you should let them know you're not getting kickbacks. for it.
what's that? That I'm not getting it.
Getting any kickbacks.
I know. So I wouldn't, yes, is the short answer, and I have seen it done. The only concern with that is that the sharp edges and the
Right.
getting right. So yeah, if you can make sure it's safe and
Skydive.
yeah, right, right, yeah, exactly, and just making sure that it's yeah, you absolutely can. If you want to build one your own, we love, I mean, that's very
Yeah, why?
protective, but you can. But again, they're not super, I think they're like $10 or something, so it's, you know, it's a reasonable, it's not super expensive, but absolutely you can. The other thing you're gonna love or would recommend is a reacher. You're again, reaching outside your base of support, especially if you've had shoulder surgery and you're operating with one functioning arm, trying to move, you know, in any direction, trying not to bend excessively. This is gonna be your best friend for reaching things. Really wanna set your environment up so that wherever you're resting, it's kind of your domain, right? You've got your water, you've got your food, you got your clothes, you got everything. But you will find navigating your pants, especially after some lower body surgery, can be quite challenging. So this is really good. And that's another thing we teach when we teach people how to use this, just use it safely to lower. And then finally, you're gonna probably get sent home with this, one of these, the beautiful things. This is called a 2-wheel walker because it has 2 wheels. There's no other special reason. There's no other real good special reason. Sometimes people will ask me, why can't I use my rollator or my 4-wheel walker? Eventually, as you progress and you heal, yes, that might be something we work towards. We don't generally, at the beginning of your surgery, recommend using a 4-wheel walker because it's just not as stable. So basically, and there is a little like sliding scale of equipment on that page if anyone wants to see. Basically we move from stability to mobility. So your 4-wheel walker is going to be a lot more mobile. Your 2-wheel walker is just going to be a lot more stable. You're going to have a lot more control, a lot more support, and you're a lot less risk of a fall with that. So not that we won't move towards that 4-wheel walker, but really this is going to be your best friend, or a standard that doesn't have the wheels too, is sometimes depending on precautions and movement. So and then, yeah, just coordinating your care, making sure you have somebody with you. It's whoever you can convince to hang out with you for however long you convince them to hang out with you is great, because you know, relying on support is important, and making sure your meals are set up and just really that you're all set to go for a while if you're kind of either bed bound or sat in a chair for those first, especially those first 48 hours where you're just learning how to kind of operate under your new, you know, pieces. My official, your new body parts. But yeah, go back. I'm gonna take this and go this way.
She's good.
You're
Yeah,
good.
I'm like a professional.
You are really.
One mic adjustment and here we go. Okay, so kind of to like pull that all together. To prepare for surgery, statistically, research wise, you will see better results if you do prehab exercises. That is like out there in the research. I think for peace of mind, fall risk reduction, getting the appropriate equipment, coordinating your care, preparing your home is like the other pieces to it. One plug I did want to make is that if you are looking for equipment, there is the community loan closet that's housed at the nursing association. So before you buy or go through insurance, you could always check there. And our contact information will be at the end for that. So now that we've talked a little bit about how to prepare, what to do in advance, then it's really kind of understanding what happens after surgery. Surgery for all of, yeah.
Go to too much of that. They take you off aspirin or Advil like before surgery, so this is a nursing question, I think,
Okay,
in terms of management for a pain. Obviously you take Tylenol, but with these movements, I don't know, like at some point, maybe the pain is gonna be a problem for me. Right now, it's not too much, but I kind of feel like pain management is gonna be an issue for you, because they take those things away from you usually. Once it can cause, you know, bleeding. So it's just, I guess it's a nursing question
I can,
for pain management.
Like, how do you manage when you're off the aspirin before the, is that what you're asking?
Before.
I live on aspirin right now.
Okay, so before surgery,
Right,
how do you manage
so
that?
I
Yeah,
think-
that is a good.
I think that you could work with your specific surgeon on that. pre-op pain
Oh.
management. And then, you know, they'll have a plan for you. And some of the surgeons will start some, pain medication right before the surgery as you're like heading into surgery. So I would say that you would be able to discuss that with whoever is going to do your surgery,
Okay.
and they'll help you
So
sort
they-
that out. Yeah, because generally you're going to have a consult, you know, like you talk to a surgeon or two, you figure out who's going to do it, you'll have a consult, and then you'll set a date, and then you'll have a lot of planning that happens at that point, and they can help you with that. But good question.
And different surgeons will have different protocols for how long you have to be off. Some
For
do
10 days.
24 hours, some
Oh.
want you off for a week. It just really depends
Okay.
on what they're worried about in terms of bleeding risk. And with minimal, with the minimal invasive surgery, bleeding risk is less of a concern than it used to be as well. But, you know, I think it's just gonna be specific to every person and what your situation is. So, yeah.
Thanks. Don't be afraid to ask the surgeon, that's what I'm.
Yeah.
Oh, yeah.
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 Advocate for your, for pain,
Yeah, cause you wanna move, I mean, you gotta do these, yeah.
Yeah, that is also something that you can work on with your primary care provider too.
Yes.
Like, hey, I'm planning for this, but right now I'm in a lot of pain. Like, what can I do? And there are some topical options as well that can help with pain. So,
Yeah.
yeah. But that actually is like a nice little segue into what we're talking about now, because we are going to talk a little bit about the pain considerations. So with the knee and the hip, they have done a lot of work in the last 10 years to have better immediate pain management. Yes.
Kathy is back on here. I had a toe joint replacement and did no pain meds by choice. Do you think it's more important for the knee to get way ahead of potential pain?
To take pain meds.
To stay on top of it, probably.
To stay on top of
Yeah.
the pain meds if you're doing it?
Sorry, yeah. The doctor, the surgeon had, said to stay ahead of the pain, of course. And I found that I didn't really need to. Maybe I took one pain pill and Advil, Tylenol with whatever was adequate. I'm just wondering whether, because I certainly will have my knee replaced at some point. I can't imagine I won't. And I'm wondering whether the pain will be greater with the knee than it was with the toe.
Oh, yes. I would say that a knee, you should definitely anticipate more pain than for a toe replacement. And I think if I understand your question correctly, is like, should you stay ahead of the pain once you have the surgery? Is that correct?
No, I know I should stay ahead of the pain. I'm just wondering whether I should be more conscientious about it, because this pain will be greater than it was when I had the toe joint replaced.
Yes, I think working with the surgeon and following the plan, because they'll kind of give you parameters, and within those parameters, you can work on what you need. So I think that the best advice, kind of generically speaking, is to follow whatever that initial plan is, until the nerve block wears off. And then you really can kind of settle into like, what is your actual post-op pain? And then try to get off of that combination as soon as possible. The biggest thing
Thank
is
you.
that yeah, sure. The biggest thing
That's very helpful. Thank you.
The biggest thing is that you need to make sure that your pain control is adequate for you to be able to do your exercises and to get up and to move around. And so sometimes people make the mistake of not wanting to take those pain meds and getting behind it, and then they can't do the things that they need to do to be safe and to get better and to rehab. And so it is definitely a fine balance of managing the pain and your mobility and comfort.
Thank you. That was very clear and understood. Thank you.
Sure. I would say the knee, generally speaking, has more pain than the hip. So a little bit more work to manage the pain. And it's not just pain meds too, it's compliance with elevating and with icing, and the frequency of that is also important to move, right? So it becomes a full-time job. And I think mentally preparing for that ahead of time is very important. You can see here for a knee, time to normal walking is 6 to 12 weeks. And that is kind of hard to gauge. It depends on how much dysfunction you had before the surgery. how long you've potentially been using an assistive device and what your walking goals actually are, but by comparison, a hip is, you know, approximately, I don't know, a third to a half shorter time frame, just by the nature of the much simpler replacement. So for a knee, the surgeon will tell you this, it's gonna take a year, and maybe 20% of the people believe it. And then they come to PT or have us in the home and they're like, I don't understand why I'm having so much pain. Number one complaint is stiffness, even at 6 months, 9 months, like, oh, but it feels stiff. It feels stiff in the morning or stiff after I've been standing for a long time. That is exactly what the surgeon expects to happen. So do not be surprised by that. Whereas for a hip, it might be 6 months and people could, you know, there might be days where you don't remember that you had a hip done. But I think for most people, they do remember that they've had a knee done for upwards of a year. For the shoulder, it's the same idea with the pain management. Shoulders, the biggest thing is comfort with sleeping. It's really hard to get in and out of bed. So like using a recliner is very helpful initially. Most of these surgeons are using nerve blocks for all of these surgeries, and nerve blocks have come a long way. People tend to get more comfort longer than they used to, but you're really not functionally using that extremity for about 4 months. I would say maybe 3 months for a rotator cuff repair, but really it's not till 4 months where you get clearance. And with Aronowitz, her rotator cuff repair, I would say 3 to 4 months if you're looking at her potentially doing your surgery. And then really full recovery where maybe you're not thinking about it anymore is 12 months. Ignore the typo. That's going to bother me.
Just a minute.
So sir, you're in the hospital generally a day, sometimes overnight. Like if you go to Portland for any of these surgeries and they know you live far away, they might keep you overnight. Also depends on other factors, your comorbidities, maybe logistics. If you're in Bangor, you're probably going home the same day unless there's a potential complication. And so planning around that and making sure that you have someone with you for at least the first 3 days would be extremely helpful. And then you're just in a full-time job. That's just being rather transparent here. You're icing, you're elevating, you're getting up and moving every 1 to 2 hours, and then you're on an exercise schedule and managing your pain, let alone, you know, your other normal daily things. So you've really got to find a rhythm with that. But then your trusty PT or OT or nurse could come see you in the home if your doctor writes orders for us to do that. And so that's where we come into play. We kind of jumped over introductions, but Kyla is an OT, Katy and I are PTs. Depending on the surgeon and what you had done, you might see one of us first, and you also might see a nurse. Sometimes people are surprised when they've had surgery and a nurse isn't requested, but it's not always necessary. And so if it's not necessary, then we'll come. And our goal in the home really is based off of what you need at the initial evaluation. We're looking at safety, mobility, pain. Are you managing your medications? Are you getting around? What do you need for equipment? What kind of education do you feel like you and your family might need in order to be successful, stay at home, avoid an ER trip, or just a massive pain exacerbation? We do service the island, Lemoyne, Trenton, off island, sometimes Swans Island, I guess we could include. And as long as you're in our service area and you meet homebound criteria, your insurance would cover it. If you don't have standard Medicare, it might be worthwhile calling our office and talking to our billing person about what that might look like for you, just to plan. We generally come within 24 to 48 hours, unless it's otherwise arranged with your surgeon. And it kind of depends on how you're doing. Your frequency of visits from us is dependent on that evaluation, and then also how many disciplines are involved and what you might need. PTs, if necessary, can also do bandage changes or removals. Sometimes people get a little worried about that as well. that also kind of covers the first couple of weeks. You're really working on your independence, your walking, your pain management, your safety, and your exercises. For the shoulder, we would be just following the surgical precautions. Every surgeon has a different protocol. Hip and knee are pretty much the same across the board, except there might be some specific hip precautions for some doctors. Like one doctor doesn't like bridging,
Which is,
yeah, like an exercise. But all pretty standard, which is why there are the hip and knee exercises and not the shoulder exercises. The time that we're in the home seeing you for therapy is really dependent on how you're doing and at the point to which you can get out to outpatient. You'll transition to outpatient. And so that is kind of a broad 3 to 6 week time frame, depending on how things are going. Again, we're just looking at independence in the home, safely egressing. Can you get to outpatient? And when you can, that's the next best step for you. And you may or may not be off the walker at that point. Some people transition to outpatient on a device and some people don't.
can you drive if you're still using a walker?
Yes. Depends on your pain medicine, and the foot that's involved. But yeah, you can drive if you're on a walker, but for a knee and a hip, it's more about the function of that extremity. I don't think we're gonna get into the exercises for the shoulder stuff. But you can move through these next couple of slides if you have more interest in knowing what's happening. But really kind of staying focused on the phase 1, 0 to 4 weeks. Immobilization means you're in a sling. Passive, PRROM, only means passive, like you're not actively moving that. And even when you are moving it, it's pretty minimal. You might be moving it up to like 90 degrees with assistance and a little bit into rotation. And you're not using it for ADLs, like your everyday tasks. You're not using it on a walker. So pretty limiting. So important to plan accordingly. And then as you get into the first and second month, you can start to do more. But looking here, even at the like 8 to 12 weeks is when you can start to do some more strengthening. So that's several weeks where you have limited use of that extremity while it's healing. These are all the terms you might see if you look in, because you can find protocols online pretty much everywhere, but they're written in therapist terms. So it's a reference for you for deciphering it, like reading this. It's like reading Spanish, essentially. What Kathy raised her hand, but I can't see what Kathy asked.
Sorry, I asked whether a Bangor surgeon would request MDI Nursing Association.
Sorry,
Or would they have their own?
say that one more time.
Would a Bangor surgeon request your association?
Yes. Yes. Actually, the service area is only serviced by our association right now. For the most part. Is that a fair statement to make? Yes. Yes. However, you may, with a, depending on your mobility with the shoulder, you may go straight to outpatient. Like if you can, if you're still able to move around and get to outpatient, I think more shoulders go straight to outpatient than hips and knees.
Yeah, I'm thinking mostly of knee.
My
Thank you.
sister-in-law just had shoulder replacement surgery, and her biggest takeaway is make sure you plan on someone to help you with the bra.
Yeah.
For a long time.
Yeah.
Front clasping is
I was
good.
just gonna say.
You best adapted
Bypassing.
or don't bother about
You
it.
never, she's definitely not bypassing.
Front clasping is
Not
the
just for
first.
some, but not
Yeah.
else. No, he was quite happy to help, my brother. I'm sure.
My neighbor actually asked, like with a community email, who would help walk her dog, which
Yeah.
I thought was very clever after a knee surgery.
Yeah.
Yes.
Very smart.
Yeah.
Yeah, and asking for help would be a good.
Right. And if you live alone, like how are you getting your groceries or maybe your mail? right? Or getting upstairs, do you have another walker up there or not? Yes, there's a lot to think through, I think, and that really makes for a more favorable outcome.
And there's community things available like Island Connections will do medical transportation if you can't get yourself somewhere, if you can't drive. And there's some volunteer organization, I think they do too, they'll do your groceries. Then there's Meals on Wheels, you have to qualify, but I think it's age dependent currently, but it's yeah, there are some really good services if you need them that can do those things if you don't have help at home, so.
So kind of short-term post-operatively thinking, full-time job the first month and then pretty consuming for the first 3 months or so. You'll be in some type of therapy at home or not. And then things start to become a little bit more normal life after that. So looking long-term recovery and expectations is that you'll still continue to see improvements for a year, possibly longer. And some of that depends on the surgery and what you had going on beforehand as well. It's important to stay consistent with your strengthening program and your mobility. And it's really important to understand that it's not a linear, line to the finish line, that you will do really well. And then you feel like you have some setbacks and you'll overcome those, but that you will be sore, you will have some stiffness, it will be tiring, it will be pretty consuming, and to prepare for that beforehand is very helpful. But over the course of that year, or even the first 6 months, you'll get back to your hobbies, your normal walking, exercising with some modifications. Some things in that time period to watch out for. And again, it's two big red ugly flags, but you will have people that will, be around you, supporting you and helping you sort this out. But you really want to watch for signs of infection. Those would be fever, redness, drainage, things that just don't quite feel right. Blood clot warning signs would be a very quick onset of pain, particularly for the lower extremity and the calf, swelling that doesn't reduce with icing or elevation, and a blood clot. Those warning signs would be, you should seek immediate attention for those. I would go probably straight to the ER for a blood clot warning sign, but if you just think that the incision looks kind of infected, I think, talking to the nurse or talking to the therapist, we can always consult our nurse, or you can also call the office where we do have access to 24-hour nursing consultation. And then just thinking about, from the safety standpoint, like the fall prevention, doing the best you can to set up your house and your equipment. So the takeaway: stay consistent with your exercises, communicate your concerns, keep a journal of your pain and your medications so that you can stay ahead of that and stay on top of your medications, and definitely involve your family members. Don't try to do it all yourself. So just remember, it's a team effort. You're not alone. Don't compare yourself to others. I hear this all the time. It's like good to have a timeline, but don't think it's an absolute. And you've got to celebrate the small wins, particularly if you've had pain for a long time. It's tiring. And so being on the other side of the surgery feels like a celebration, but sometimes it feels a little surprising that there's still pain. This is our contact information, where you could also call if you have any equipment needs or questions. Do you have any questions to the wide audience here?
No, but I'm gonna send it to my mom, the
Ah.
presentation, if she needs knee replacement. I think that's really good information. I think the preparing is huge, and not something, unless you've got a provider who's really gonna push the getting prepared piece, people don't think about it. It's great when people come into the loan closet, a couple weeks before their surgery and say, I need this, and then they say, Katie, what else do you think I should need, you know, what else could be useful, and we load them right up. Because you don't really know, 2 flights of stairs, what's the bathroom situation, who's available to help, what kind of community do you have, there's not family or the neighbors there. It's. Preparation is huge.
Well, and I think that joint, elective surgeries have evolved so much in the last like 10 to 15 years. And so the idea that you're gonna go and be in a hospital and then like go to a rehab, like those days are kind of gone, right? And so all of a sudden people are home and it's a little overwhelming. It's like this morning I was on an operating table and now I'm home. And you've got, it's just a lot to manage. But also outcomes are so good now. So I think that's a little less daunting. You're not worried as much about infection control, infections, and the pain control is so much better than it used to be. So
Way better. Probably if you have double knee replacement, you would go to rehab or not?
I don't know many
My husband
people.
had doubles, and I don't know how to manage.
Was that recently?
I don't know, I think it was quite a while ago.
Yeah, they're not doing doubles as much. They might separate them by like a month, but usually it's a couple, 2 or 3 months.
I wondered if it was too hard on your system, really.
Yeah,
Yeah.
yeah. And I think because they try to send people right home
Right.
for infection control purposes, that is one of the reasons why, in addition to kind of how taxing it is on your body, but it takes a strong person to then go back 3 months later, like
To do it again.
yeah, to do it again. That's like childbirth,
You need a little recovery.
That's why I have one child.
You didn't forget.
Right.
Well, I'd just like to thank you. This was an incredible presentation. I really appreciate the detail that you've gone to. So
Well, thank you, Kathy. Thanks for joining on such a nice day too, from wherever you are.
Yeah, I know. I'm just in Bar Harbor. I was going to come, but then I saw it was also available on Zoom. So I thought, well, I'll save the driving time.
Thanks. Is it possible for us to add the slides to the link that I'll put up on the YouTube for the recording so that people will have access to the slides?
That sounds very tech savvy. You just tell us what you need.
Yes.
Correct the typo.
Yeah, I'm holding it hostage, so that's good. You just need to let me know how you need that. Yeah.
Just to get the typo fixed and I can do
Well, I won't lose sleep on that.
Do you have a handout that you're giving for the exercises out of curiosity? Maybe I could pick one up sometime.
Email it. It was emailed to me through Katy, so.
Oh.
Sure, you can upload it.
Do you, there's a couple different things here. Do you want the exercises or?
The others, unless you want the home. But
No.
yeah, the exercises.
I think this is a great one.
You like the-
They're both wonderful. Okay. This one's very good for planning.
Okay.
Do you want to put your email address or your mailing address and whatever way you prefer?
Sure.
Oh.
Which do you prefer?
What we'll do is you'll pass me all of the links or the whatever it is, and then I'll upload it when I post the video. And it'll be in the description, and then everyone who signed up on registration will get an email, including you guys or whoever, when it's posted, which hopefully will be today or tomorrow. It'll be great.
Got it. Okay.
Thank you.
All right. Okay, great. Thanks. Have a good day.
You too.
I did do a fall prevention, just like, I don't know, 6 months ago, maybe a year ago. And that's why I'm here today. It's very educational, fall prevention, and I fall all the
Yes,
time.
you were in the same seat, right?
Probably.
I think I was like, you look so familiar, and that is probably
So,
why. Yeah.
Thank you. My physical therapist said, yeah, you're supposed to do 11 pop-ups in 30 seconds.